mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect. Real talk from doctors who look like you and get it. Lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
A very good morning to you all. Can you hear me?
Yes, we can, Doctor. We just can't see you.
Right, okay. Right, apologies for that. Would you like me to switch to the other device?
Yes, in the meantime, please, yeah, please do so.
Okay, while we sort this one out.
Yeah.
Okay, thank you very much.
No problem.
Thank you for your patience, everyone. Thank you for joining us this morning on Health Hour with the Caribbean and African Health Network. It is my joy to be your host for this morning. Please bear with me.
Oh, we can see you now, Dr. Von.
Fantastic. Thank you very much to you all. Thank you for your patience with that little bit of IT glitch. My name is Dr. Von Shuro, and I am a GP. I'm a portfolio GP based in London and different places in the UK. Today, as I just mentioned, it is my pleasure to be your host for the Health Hour hosted by the Caribbean and Health Network, as we talk on one of the most important chronic diseases that affect our people, our time. Well, it's transgenerational, it's transnational, affects all age groups really, and it's so important. So it is my pleasure and joy, without further ado, to introduce you to our speaker for this morning. Our speaker is Dr. Raymond Njafuh. Did I say that correctly?
Njafuh.
Njafuh, sorry.
Yeah,
Yes, thank you so much. So, yes, so Dr. Raymond is joining us this morning. He's a consultant in lung and respiratory medicine based in the Sussex hospitals, well, in the trust, based mainly in Worthing. So he's going to talk to us today about asthma and lung disease. I know I've not done justice to that introduction, Doctor. Would you kindly just, in a few seconds, just tell us a little bit more about who you are and what's brought you, what's motivated you to share with us today?
Yeah, absolutely. Thank you, Dr. Vaughan, for such a kind introduction, and thank you to Can for giving me this opportunity to share to the masses my passion about asthma and airways diseases. As Dr. Vaughan has mentioned, I am a respiratory consultant at University Hospital Sussex. I'm currently based at Worthing Hospital. And I have a keen interest in a lot of respiratory diseases, lung cancer, pleural diseases, and the virtual wards. But recently, I've also taken up the post as the lead for airways disease in my hospital. So airways disease being asthma and COPD. I am very honored to be here to talk about what asthma is to you all.
That is fantastic. Thank you very much. It's asthma, it's really quite a scary condition, isn't it? And I think a lot of our viewers are interested this morning because sometimes we don't always know what to do or the best things to do to avoid it. Is it preventable? And we hear all sorts of things on the news about asthma deaths, and how to prevent them. So we would really like you to go deeper into telling us how common this condition is, how it specifically affects the Black community, what are the things that trigger it or cause it, and anything else that you have to share with us. So please, the floor is yours, Dr. Raymond.
Absolutely. And I hope I will do it justice to cover all the points you have mentioned. So thank you very much. What I will do is let me share my slides. Right. Is that visible?
It is coming on, definitely. And I can see a wonderful blue and white slide there. Thank you.
Excellent. So that is presentation. Again, thank you very much, Dr. Vaughan, and thank you again, Can, for this opportunity. And I am really impressed by the work Can is doing to address health inequalities in our population. So every little that we can do as healthcare professionals to support this goes a long way. So I'm honored to be here. So I'm a respiratory consultant, as I said, at Worthing Hospital. And it happens to be that Tuesday next week is World Asthma Day. So what a time for us to talk about asthma and lung conditions in general. So what I will do is this session today, I will try and go through things as detailed as I can, but to keep it very brief and simple as well. So we'll have a general overview of what asthma is, what the causes of asthma are, and the common triggers and warning signs to look out for. We will then briefly look into treatments and how to manage asthma. And then we'll go through some lifestyle tips and advice on specifically when to get help. I will then briefly touch on other common lung conditions which sometimes can mimic asthma, or conditions which I feel we should just be generally aware of, because all breathlessness is not asthma. Of course, I missed all of this. We will be looking at some data and statistics on how it affects our population, the Black population in general. So why does this matter? Why does asthma matter? So we all know that lung health is essential. That one is a given. It's essential for life. And if any of you are healthcare professionals, you will know that whenever there is an emergency, they always ask you to start with an ABCD approach to treatment, and A being airways and B being breathing. Those are the two common first thing they need to make sure. Are you breathing? So we know your lung health is life. Okay. Asthma does affect millions in the UK and worldwide, as we will see shortly in the next slides. It's a huge burden of disease worldwide. And the interesting fact is, for some reasons, which we will try and go into on this talk, is it disproportionately affects the Black community more, and we will try and look at some reasons why. And why are we talking about all of this is because many of the complications that result from asthma are preventable. A lot of them with proper education and management. So this is just a general kind of overview of asthma globally and the prevalence. The current estimate by the WHO is that it affects roughly about 260 to 270 million people worldwide. But those figures are actually very conservative, because if you look into detail, it only really includes people who are reporting symptoms or diagnosed. The actual estimate with those that have not been diagnosed, or the prevalence of it, should be getting close to about 350 million worldwide. And this figure, which is, if I can get my highlighter, is the annual asthma death worldwide is almost getting to 500,000 every year. That's a high number for a disease which is easily treatable and preventable. As I mentioned earlier, the lifetime prevalence, if you do ask in just some survey, actually is getting roughly to about 10% of the world population, which is incredible. What is also clear is that children and adolescents are actually the most affected group in most asthma. In fact, it is the commonest chronic disease in childhood worldwide, bar none. Okay, so it's an important problem. It's something that we all need to look out for and to address. So what is asthma? What is asthma? In kind of the basic term, asthma is a long-term condition that affects the airways. And what are airways? Your airways are the tubes, the passages that move air from when you breathe air in, it passes through this tube before it gets to the lung tissue itself, or the alveoli, for it to then go into your system. So these tubes are what they call airways. And there are different sizes of this tube. So these are the bigger tube. This one is called a trachea, and it branches into two, and it goes into more smaller tubes going down. And those are the smaller airways or tube that asthma predominantly affects. And what happens in asthma is that you get this scenario. If you look at this side of this illustration, this is what a normal lung tube or airway should look like. Okay, with the lumen here, which is where air goes through, it's nice and clean with no problems. Okay, the muscles are all working fine. While in asthma, you get this condition where, one, the tube becomes narrower because of inflammation, and then you get quite often that area being filled in with mucus, and the muscles around that windpipe, because they're very sensitive, they tend to constrict quite easily. So the consequence is you get these inflamed airways, narrowed airways, and they are very sensitive to trigger. And what that means is people with asthma then will struggle. If you can think about it, there's not much space here for air to move in and out. People will then struggle to breathe in and out, resulting in a classical symptom that we find in asthma, which we will go through shortly. Now, what causes asthma? It's a busy slide, this, and a bit complicated, but the take-home message from this is that asthma, there's no one thing that you can pinpoint and say this is the cause of the asthma. On the contrary, the way we look at it is it's a complex kind of interaction between our own genetic composition and the environment that results in the disease called asthma. So most of us are born with an inherent risk of having asthma, some more than others. And especially in the Black population, we may have a bit more tendency to become asthmatic. But that's not the end of the story. There has to be some environmental exposure. Some things must happen within the environment for that tendency of asthma to then manifest as a disease. Quite often, which is why sometimes some people may not get asthma symptoms until they're much older, just because that's when the environmental exposures have got to the point where it's tipped over and result in disease. So what happens is, because of the genetic susceptibility at the beginning, if you're then exposed to certain factors, for example, lots of air pollutants and irritants, virus infections that infect the lungs, damp, mold in the environment, and some things that we use for work, for example, some occupational stuff like flour dust, paints and fumes, cleaning agent. Over time, as we inhale these things, they cause irritation of the windpipes and the airways, and then they can then trigger this type of what they call immune dysregulation, which then results in your body almost attacking itself, in that it just produces excess amounts of these inflammatory agents that result in chronic inflammation in your lungs and your windpipe. So in essence, one cannot point to one single thing as this is the cause of asthma, but if you look at it more as a complex condition where your genetics in combination with the environment results in the end disease, which is asthma. Now, what are the common symptoms that people with asthma may present with? And it's important to recognize some of these symptoms, because we quite often may know this and ignore them. The commonest one is recurrent wheezing. And wheezing is if any of you have ever heard one, is that almost like musical polyphonic sound that happens when people usually breathe out, but it can also happen when you breathe in. So that's what's called wheezing. Commonly, people with asthma will be breathless, and that breathlessness is usually when they are trying to do things. For example, if you're trying to exert yourself, do a bit of exercise, you may notice you're a bit breathless. And quite often it may be associated with some tightness in the chest. And the final one is coughing. Now, coughing is sometimes could be the only symptom that some people have without any of the other ones. Hence why, if you have a chronic persistent cough for several weeks, which is not going, it's always worth to have it checked, because asthma sometimes can present just with a cough. Usually people with asthma and their coughing tends to affect them more at night. So if you're waking up in the middle of the night with a cough that's really not going away, it's quite often a dry cough, but it may be productive. But if it's persistent for more than 8 weeks, then you need to have that looked at. And the red flag symptoms here, which is a hallmark of what asthma behaves like, is symptoms that tend to come and go. Okay, just because of the nature of asthma, where your windpipes get inflamed, but they are reactive in that. If you take a medication, the windpipes can become back to normal, or if whatever had caused the irritation to cause inflammation at that time has settled, the windpipe may reopen itself, so the symptoms may go away. but then come back again when set trigger is in the environment. So symptoms that come and go should make you concerned, and symptoms that worsen in certain conditions or triggers, which we will look at next. And the thing to also be aware of is be aware of the silent symptoms, the ones that is not really causing you any trouble, but you think, oh, well, my chest doesn't quite feel right, but it's not bothering me, and then just leave it be. Beware of that, because if asthma is left untreated for some time, it does cause problem down the line in adulthood. So what are the common triggers for asthma? So this is not an exhaustive list, but these are the commonest things that can trigger kind of an asthmatic attack or asthma type symptoms in susceptible individuals. And these trigger often vary from person to person. So no two people would say the same thing cause problems in them. So it may be in one person, it's that they have a pet at home and that's what they're having problems with, but they're okay with everything else. But in some people, it may be a combination of all of those. So air pollutants, pest, cleaning products, we've mentioned, smoking, tobacco, very bad. Now pets, especially cats, birds, they've been implicated, or they can cause asthma symptoms. And important as well is mold and damp in the house, which is quite often underlooked. The other things to also be aware of is just changes in weather can be enough to trigger symptoms in some people. So just suddenly walking into a cold environment, cold air is enough to maybe cause that spasm in your lungs and cause symptoms related to asthma. We've mentioned virus infections. This may usually be the final trigger that bring forth symptoms of asthma for people to recognize actually they're asthmatic. Things like dust and house dust mite, pollen, and in some people actually there's a variant of asthma called exercise-induced asthma, which only tends to happen when people do strenuous exercises. But it doesn't have to be strenuous. Sometimes it's minor exercise. And the last common trigger is stress. Now, how do we go about diagnosing asthma? The key thing in the asthma diagnosis is symptoms. So 80% of the time, we will be able to know that you're asthmatic just based on your description and pattern of your symptoms. And quite often it's enough for us to even initiate treatment based on the history that is suggestive. And the history is what we've already gone through. Those symptoms that come and go with certain trigger, and wheeze, persistent cough, those kind of symptoms. Now, once we've got that, it is quite often useful to then have a more objective finding to prove that there is definite what we call airflow obstruction or airflow limitation, which means we will do some tests to check if you're breathing, when you breathe air in and out, there is a limitation in the flow, which would mean that the airways are narrowed. And that test is called a spirometry. And it's just a breathing test, and it gives us a number which can indicate whether there's blockage or limitation in how much air you can blow out. And quite often they may give you some medication or some inhaler to try and then retest again. And then the hope is that with the inhaler, the lung or the breathing test will become normal, which is a classical definition of what asthma is. The other thing is something called a peak flow. Some of you may be familiar with this if you're asthmatic. You may know what one of these devices are. That's what is called a peak flow meter. And all it is, it's a basic tool which just they get you to blow in quick and hard, and it measures how quickly you can get air in out of your lungs within a few seconds. And if there's a reduction of what we expect you to achieve, then it's maybe a sign that there is narrowing in your windpipes. And quite often we will give people a book, or what they call a peak flow diary, to keep at home, where they will record this reading morning and evening, and put the numbers. And what we look for is changes in that value with time. If there's significant variation in what someone's peak flow, it's highly suggestive that they've got asthma. And we quite often will do other tests, usually a blood test, to check if there's signal in your blood that you have allergic type tendency, which may indicate that you're more likely to be asthmatic. And there are some other advanced tests that can be done more so in a hospital setting or tertiary center if your asthma continues to be a problem. So this is usually enough for most people to diagnose their asthma and start them on appropriate treatment. Now, in terms of treatment, what are the treatment principle in asthma? There are three simple goals when we try to initiate treatment in asthma. One of them is to get your symptoms better quickly. And that's important because when people get an asthma attack, they get really breathless, and you need to relieve that symptom at that point quickly. The next thing, which is actually the most important element of treating asthma, is treating the underlying inflammation that's happening in the windpipes, in the airways. As you saw in that post or graph I showed earlier, there is a lot of complex inflammatory response by your body that happens that results in this chronic inflammation in the airways. If we only treat the symptoms and not manage that inflammation, we're not doing it any justice. And what would quite often happen is people would have recurrent asthma attacks and end up usually with severe attacks and hospitalization. So the aim of treatment is to address these three things: symptoms, treat underlying inflammation, and by so doing, prevent and minimize severe attacks and hospitalization. Now, so, and I have displayed two inhalers here, which people may be familiar with. But the reason I've displayed this is recently there's been a change in guidance on what we should be doing and treating people with asthma. Now, before, anyone who is asthmatic, depending on your level of symptoms, they may give you what they call a blue inhaler, which is this one. And this is a standard, usually salbutamol inhaler. And all it does, it's got some medicines in there to just open up the airways and make you breathe better. And that's all it does. It works within a few minutes and people find it very good. They think that's solving their asthma. It is helping symptoms, but unfortunately, it does not treat asthma. Okay, so some people may still have this, which is fine, still use it when you're symptomatic, but what everyone must have is what they used to call previously a brown inhaler, but we change it now to just a steroid-based inhaler. So every single individual that has mild, moderate, or severe asthma should be on a form of inhaler that has steroids in them. Why is that? Because steroids are anti-inflammatory. Steroids are the things that treat that active inflammation in your airways, in the windpipes, and then minimizes your risk of developing acute symptoms and your risk of having severe attacks that leads to hospital admission. So this is the important aspect of the treatment, not this. In fact, the hope is that if you're using this enough, you should never need to use this ever. If you're using this blue inhaler, it's a sign that the inflammation, it's still not adequately controlled. So the move now is we're trying to, for any new person who is diagnosed with asthma, we don't give them any blue inhaler anymore. We just give them an inhaler which has a combination of steroids in them and a chemical, which is usually in these medication, combined in one inhaler, which means they're taking two drugs in one at once, and they're treating both their symptoms and the inflammation at the same time. Okay, so I did mention at the beginning it's World Asthma Day on the 5th. So and their theme for this year for the is access to anti-inflammatory inhaler for everyone. Okay, so it's emphasizing the need for everyone to have access to some form of steroid-based inhaler once they're diagnosed with asthma. Now, what are the warning signs that you may be having an attack? We probably touched on some of these briefly already, but I'll just re-emphasize them again. The first thing is if you notice that you're using your inhaler more. Now, we've said reliever inhaler here just because some people still have that reliever or blue inhaler. If you're noticing that you're using that inhaler more than 3 times a week, that's not good. It's a sign that things are not right in there, and there's a sign that you may be having, or you may have an attack soon. Or in the newer guidelines, if you're using extra doses of your inhaler or needing to, that also is a sign that things are still not quite there yet. Of course, if you're getting more breathless despite your inhaler, it just may be a sign that whatever inhaler you're on is just not enough. And you may need more, or there may be something else going on which may not be asthma related. Now, anyone that's breathless enough to not be able to complete a full sentence without stopping, it's a bad sign. So it means you need to seek help urgently. If you're talking and punctuating because you want to catch your breath in between, that kind of talking, it's usually a sign that an attack may be imminent. And those who have nighttime symptoms which are persisting despite the inhalers also should at least seek help to have their inhaler optimized or additional treatment on them. Now, the emergency signs there, I mean, we will hopefully all be able to recognize this. If you see someone that are too breathless, that their lips are turning blue or they are exhausted, obviously it's a sign that they're having a severe attack and should really be, you should really be calling an ambulance for them. And those that when they take their inhaler, they just don't feel any relief from their symptoms, may be a sign again that things are not well controlled and they're at imminent risk of an attack. And early help, as I say, early intervention in all of this is what usually reduces risk of death and hospital admissions. Right, so this next slide is just talking about the prevention. How can we prevent things getting worse to the point where there's hospital admissions or even death, and what works? In my experience, certainly in my clinic, whenever someone comes in and I'm reviewing their asthma, the 2 commonest reasons why their asthma is either not well controlled or they're having attacks is they just don't use their inhalers regularly. Okay. Or if they're using it regularly every day, they are not using it correctly. So those are the 2 most important things to ensure that it's happening. So first thing is, do they have the right inhaler? Do they have the right inhaler for that person? Every individual, as you can see from the picture up here, there are so many different inhalers. The last time I checked, there were up to about 200, 250 different types of inhaler and inhaler devices. So picking one inhaler for everyone is not the right thing to do. Every individual will get on differently with different types of inhalers, but the principle of managing the condition is the same, because most of these inhalers have similar medication or in different combinations, but in different delivery systems. So, so the first thing is what inhalers do you have, and are they working for you? And quite often what I do is I tell everyone coming to my clinic, bring your inhaler with you. And then when they're in clinic, I tell them, show me how you use your inhaler. And the number of times people do the inhalers wrongly is that's about 80-90% of the time. So it is incredibly important that you know what inhaler you're on, make sure you're on the right inhaler for your condition, and make sure you're using it correctly. Because if the medication doesn't get into the right place, if it doesn't get into the lungs, into the windpipes, you're not treating anything. So those are the two commonest reasons. Now, the next thing to make sure that you're preventing problems is avoiding known triggers. If you know that certain cleaning products sets you off, avoid those products. In fact, do away with all of them. If you have mold, damp in the house, try and get the landlord to do it, get the council to sort it out, or if it's your own private property, make sure it is sorted. If you have a pet at home, which is usually the common reason, so people are quite attached to their pets, cats, dogs, birds, they are quite attached to them. Despite it causing quite a lot of symptoms to them in terms of asthma, they may still persist with this pet because they don't want to get rid of it or rehouse it, and they're waiting for the pet to meet its natural end. But what I tend to tell my patient, if you can't do away with it for any reasons, then don't get another one when this one goes away. So if the person, don't replace it with another cat if you know that the cat is your trigger for asthma. So avoiding known triggers is also a very key component. And the last one on the list here is, if you've been diagnosed with asthma, don't just take your inhalers and then get on with things. Make sure every year at least you have a review of your asthma, either at your general practitioner or nurse-led, or in the hospital, depending on where you're being followed up for this. Yes, most people with asthma have mild symptoms, but it does not mean that you do not need an annual review, because quite often what they'll pick up from that review is that, oh, this inhaler you're using may not be the right one for you. We may need to change it to a different one. Or what you thought maybe that your symptoms is actually well managed, when they did some other objective test, your windpipes is suggesting that you still have chronic inflammation that needs managing. So it's important to have this annual review. And as I said, most asthma attacks are preventable with proper care if we do that in advance. Now, lifestyle and lung health in general, this kind of general advice, not just for asthma per se, but just your general lung health is important. Now, smoking is obviously top priority for the lungs, in that we know it doesn't cause not just asthma, it causes other lung conditions, including chronic obstructive pulmonary disease and lung cancer. So if you're a smoker, I would really strongly encourage you to consider stopping. Tobacco dependence is a problem, and we know that, and it's not easy to stop sometimes. But with the proper help and support, there are lots of community services available to help with stop smoking. That's, I cannot overemphasize this point. The next thing is stay physically active. Your lungs will thank you for it as you get older, as you maintain. As we're growing up, the way you build your lung capacity as you're growing up is by being as active as you can, and then trying to maintain that level of activity. Because unfortunately, as we all get older, our lung capacity declines, and that's a normal, natural aging process. But whatever baseline you achieve at your early adolescence and adulthood sets you up nicely for you to maintain a good, healthy lung in over the course of your life. And maintaining your level of activity, even when your lung function may be limited, is still incredibly important. And on physical activity, maintaining a healthy body weight. Not just because weight is directly implicated to asthma and developing asthma as well. It also puts you at risk of other lung-related conditions like obstructive sleep apnea, which we will touch on very briefly at the end. Improve your indoor air quality. Now, this is something that people may take for granted, is that good ventilation in the house goes a long way, because we all use like lots of cleaning products, lots of air fresheners. These products have what they call volatile organic compounds, and if you keep them trapped indoors, they're harmful for your lungs. Okay, so proper ventilation is really important to make sure that any of those volatile compounds, they leave your property as you clean them. And also things like house dust mites, which builds up over time within our houses, and mold, those can be sorted out with just proper ventilation, good ventilation within the property. And the last at the bottom there is keep up with your vaccinations. Quite often, if you do have a chronic lung condition and you're of a certain age, we really insist that yearly flu vaccinations, for example, are a must, and other vaccinations as offered, usually the pneumonia vaccine, booster vaccine, if you don't have one at the age of 65 or above, or COVID vaccines as offered. The reason being, asthma and other lung conditions just make you more prone to infections in your lungs. And these vaccinations have been shown to not just prevent the infection, but if you do unfortunately still pick the infection, the disease itself is not as devastating as it could be if you were not vaccinated. So that's important. Now, just looking generally at the our Black population in the UK and the burden of asthma when we compare it to the white population, and this is this information actually is quite stark in terms of the differences in the risk of death in asthma in our population. So if you look at the risk of if you're Black or Black heritage, you're almost 4 times as likely to die from asthma if we compare to the white population. 4 times more likely. That's incredible. And you are twice as likely to be admitted into hospital for asthma or asthma-related problems, again, when you compare to the white population. And in childhood, kind of, again, very similar tendency in childhood in terms of admission, in that a Black child is almost twice as likely to be admitted due to asthma than a white child. So this makes you think, or makes us think, doesn't it? What could be the reason? Is genetics the only reason behind it? But unfortunately not. I would like to say that's the reason, but it's not. It's a lot to do with how us and our community, we approach chronic disease management in general, but also asthma in particular, and also the environment we live sometimes, or most of us, is not quite conducive, and it results and puts us in a much higher group. So it's not just our genetic composition that makes us more susceptible. So the key theme and the key risk factors is environmental exposures is the key ones, and the social aspects of things. Okay, so we do have higher levels of deprivation in the Black community, and quite often our houses are a bit overcrowded, and we do sometimes just ignore things in the house. For example, when there's I mentioned about ventilation earlier, when there's a bit of mold in the house, there's a bit of damp, all of those things. We are often quite busy that we may just ignore those elements and not quite realize how it is affecting our long-term health. Now, the other issues are there things that we think psychologically could be the reason why? In that, do we trust our healthcare system enough? Because of past experiences, maybe not. Do we believe when we go to our doctor and they tell you, you have asthma, this is your treatment? You look at it and go, oh, I'm not sure. And is there almost like a stigma around chronic disease in our population? In if they see you constantly taking a certain medication or inhaler, is it more, are you admitting that, oh, I have a chronic condition? So you would rather just ignore those and hope that this treatment is not necessary. And the other issue is delaying in getting diagnosis. Most often, we will ignore our symptoms, or we just don't recognize that this symptom is something we should be worried about, which is why talks like this, organized by CAN, to kind of highlight some of these issues that we may think, oh, it's not necessary, highlighting them to say, actually, that cough you've had for the last 3 months, it's not going, you're waking up at night. It should be something you should have looked at. It goes a long way. So, and there are a few other things on there. So all of those factors put in together, unfortunately, is the reason why there are higher death rates in our group for asthma, and more so we're likely to be hospitalized with asthma, just because we leave things to the point where by the time we recognize that it's a serious problem we need to deal with, things are often too late. Okay. Now, finally, as I promised, I will look at very briefly, I know I'm short of time, briefly of other lung conditions, which we should be aware of, because again, as I said, not all breathlessness or cough is asthma, especially in the older group. So there's this other condition called chronic obstructive pulmonary disease, or in COPD in short, which is quite common, but it's almost exclusively a disease of smokers. However, there are certain things that if you've done in the past, certain jobs, or you've been exposed to certain amount of fumes, which if some of us grew up in Africa or the Caribbean, where you cook with firewood indoors. All of those exposure can increase your risk of developing this condition called COPD. And what it essentially means is your windpipes becomes chronically inflamed, similar to asthma, but it doesn't respond to most of the inhalers that you take for asthma to open up the windpipes. Okay, often people will end up with a chronic cough, which usually will be bringing up some form of mucus. They will be chronically breathless, especially when trying to do exercise, and they're a lot more prone to infection. Now, treatment for it is, unfortunately, it's a condition that's not reversible, but it's manageable in terms of reducing your frequency of infections and preventing you progressing into quite severe disease. And how we do that is by, again, some inhalers which are licensed for COPD, stopping smoking if you're still smoking, keeping yourself active as much as possible, and again, vaccinations to minimize your risk of lung infections. The other condition I want to just highlight very briefly is something called pulmonary fibrosis, which is just scarring in the lungs. This one, again, there are certain jobs that we do that may put us at risk of developing this condition, but quite often it is a condition of unknown cause. It just means for some reasons your lungs just start scarring. It's a condition which again is not reversible, but there are newer treatments which can slow down this condition and minimize progression over time. The symptoms for them is breathlessness again, usually a dry cough, and often just general tiredness and weight loss. And how do we treat it? I said there are some newer medications that can help. And the way they diagnose this is you need some examination and a scan, and your GP or a healthcare provider can refer you for all of that. And keeping yourself active is key. And the last one, which I think is important for specifically our population with rising levels of obesity, is this condition called obstructive sleep apnea, partly because it's very under-recognized as a condition. It's usually a condition where essentially when you're sleeping at night, your upper airways, your throat closes and stops you from breathing for a few seconds, to the point where you wake up. You may not wake up physically, but your brain wakes up, and then that cycle continues. Whilst we may think, actually, is that a problem? We may think it's not a problem, but it is, because if you do not have a proper sleep, your brain doesn't sleep, it has long-term effects on your whole body, including your heart and your risk of heart attacks and strokes. And how do we know? Someone has always said they may just be generally tired and fatigued during the day, a bit more sleepy. You may often wake up feeling you're not really rested, even though you feel you've slept all night. You may have trouble concentrating, and quite often they may mention that you snore. And what's not listed here is breathlessness. Sometimes people would just always say are breathless as a consequence of that condition. And the reason is important is this treatment for it is simple, twofold. One is losing weight and exercising more is sometimes enough to cure this condition entirely. But if weight loss is not enough, just having what they call a machine to help at night, so-called CPAP, can help minimize these symptoms, but also the long-term complications that come with it. So see a doctor, as I say, if you have any persistent cough, you're breathless, if you're having wheeze or chest tightness, frequent infections, or if you're just feeling that you're tired daily, and despite having a good sleep. So, because all of these conditions, when you recognize them early, there's something we can do about them. Now, briefly, as conclude, so the key take-home messages today are know your symptoms. Okay, so you are the main advocate for your health. So know your health. So know your symptoms. Know when things are not right. Other issue is use your inhalers correctly. If you've been prescribed inhalers and you feel they are just not working, they will look for alternative. They will do checks and make sure you're able to use the inhaler properly. Empower yourselves. There are lots of websites with videos on how to use the particular inhaler you've been given. The reason I haven't shown you how to use a specific inhaler in this talk is there are so many of them, and showing you how to use one may not be helpful. So the individual inhaler you've been given, look at videos on how to use them, how to get them properly in the right place. And don't ignore your signs when things are worsening. Don't ignore that cough that's worsening. Don't ignore the fact that your inhalers, you're using them, it's not really doing very much, but you're functioning with it. And seek help very early. Lung health is protectable, so let's do that. And thank you very much.
Wow, 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 wow. What an awesome presentation. Very clear, very concise, very simple to understand. I am so impressed, Dr. Njafuh, for just how amazingly you have compressed such a big topic and broken it down into very, very understandable information for our viewers, for the Black community. Thank you very much for that very wonderful, wonderful presentation. And an additional sort of comment on other conditions. I think we need to invite you again to really go into detail about all those other conditions so that our viewers can be helped. I mean, particularly for me as a GP, you've really been music to my ears, talking about engaging with the GP with the annual asthma review. You know, this is a free service that's available for our patients who are affected by asthma, and it is a very good resource to ensure that their vaccinations are done, to make sure that they've got support to lose weight, to make sure that they've got access to support even with physical activity, referrals to programs that can help them not only lose weight, but become more active and engage in a healthy lifestyle. We've got endless amounts of resources in the NHS with regards to smoking cessation and help to stop smoking. So all of those things that you've mentioned, I think, are so critical, and I really want to particularly thank you for highlighting that to our viewers. Now, I'm aware that it is the health hour, so technically the hour ends in 3 minutes. However, if you don't mind, Dr. Njafuh, we do have quite a number of questions from our very keen, engaged viewers who have been sending through their questions throughout your talk, because they are really being helped by what you're saying. So our viewers, I want to welcome you again. If you joined us after Dr. Njafuh started talking, welcome to the Health Hour, and thank you for your patience. And if you can spare a few more minutes, 15, 20 minutes, if it's okay with the admin team, just for us to go into the questions. But of course, if you've got an appointment or a weekend engagement that you need to leave at 12 o'clock prompt, by all means, do leave. We know you appreciate, and we know you can always also play back this recorded session and make sure that you catch up on all the information that you have not heard. Now, so swiftly, I mean, I would like to start by acknowledging Naz Hussain. Naz Hussain is a passionate professional, Dr. Njafuh, who is from the Black country and has got an interest in advancing health equity. He or she says she would love to collaborate in the Asthma and Lung UK clinical roles. So maybe you can catch up and make a connection there, network, so that we can join in this fight to bring more equity to asthma care and asthma management in our people. Now, Naz as well asked a question, and it's around how people use language to express themselves. And I think sometimes this is a factor in people recognizing or admitting. You know, it links into the idea of health beliefs. And I know you haven't touched a lot on that, but, you know, Naz's question is, are there any other words used in everyday speech to describe wheeze in Black communities, or indeed any of the other symptoms that you mentioned, because the description of symptoms is critical to our human experience. And a lot of us, English is not our first language. And so sometimes we don't always connect with what the healthcare professional is telling us about our condition, because we're not sure that it is what we're experiencing in our own words. Are there any other words in English, or I don't know, any comments on health beliefs and language in the experience of asthma?
Yeah, so that's a very good question, and thank you for asking. Just starting on the subject of the symptoms and the words, the difficulty with wheeze is the patients. Most people wouldn't come and tell you they're wheezing, because most people may not know that word, and all they will tell you is I have noisy breathing, or my breathing sounds like it's making a funny noise. So you will then you'll be the one to work out whether that is a wheeze or that type of noisy breathing. How do we get the layman to understand that? It's a difficult one, I have to say, because you would really just have to rely on them coming forward. And when you're asking the question in the histories, when you breathe, does your breathing sound a certain way, or does it? And sometimes you may even have a clip of what a wheeze sounds like and say, does it sound like this? And then they may go, okay, yeah, that's what, or my child, that's what they sound like when it happens. So and the other symptoms of breathlessness, I don't think there's any other word you can use. Are you struggling to breathe? I guess so there's no other word that you can really use to describe breathlessness as such. Now the second, what was her second question? I think it was.
Yeah, I think as part of that, actually, she elaborated further, and I think you touched on how patients might express themselves, and and more importantly, I think there's a thing to be said about medical education or education of healthcare professionals to move away from sort of standard medical terminology and really express things in layman's terms. How can we help clinicians avoid misinterpretation of that communication? So if a patient says, I think my breathing is noisy, or I hear sound when I breathe, or is there any comments to support some clinicians, not just doctors? We know we've got advanced nurse practitioners. Nurses actually take a lead in asthma care in the community. Any advice on that?
Yeah. So what I often do is because we do have access to lots of all the other records. And what I look at is pattern of symptoms as well. How often they've come in with set noisy breathing, and then look at what they may have written down, whoever assessed them at that point. For example, if I see someone in clinic and they just said, oh, their breathing is not right, they have some funny breathing or noisy breathing, and they said I was in the A&E ones, what I'll do is I'll quickly have a quick peek through the A&E records and see what did they document in their assessment. And quite often you see that they will write what type of abnormal breathing they had and what their respiratory examination was at the time. Now, I realize that's not helpful in every scenario, and quite often you just need to dig deep. And as I said at the beginning of the talk, 80% of your decision on the diagnosis of airways disease or asthma specifically is around the history and the pattern of symptoms. So if you spend as much time as you can trying to elucidate exactly what their breathing trouble may be, and most people, you can get it out of them. They'll be able to tell you what situations they get breathless, what the triggers are. And as I said, if you have a phone, you can play what a wee sounds like. Again, not everyone is wheezy with asthma, so just trying to get that out there. Not everyone is wheezy. Sometimes some people may just have a cough, like a really chronic cough, which is mostly at night. And it's then us as the healthcare professionals to try and put the pieces of the puzzle together and then come up with what the most likely cause is.
That's wonderful.
Yeah, and the other thing is, and again, as I said, not every breathlessness or noisy breathing is asthma. So there are other lung conditions. So it's important to get the history right and then target your investigations before then putting a label of asthma on someone.
Thank you. I think you've answered that really comprehensively, and I hope that was useful. Now, moving on to the next question, shout out to Donna. Donna, Dr. Njafuh is actually on the call right now in the talk, and she's affected by asthma. She's had it for over 30 years. And she says that her symptoms have improved following a change in her preventer inhaler, which is fantastic. But her question is, are there any long-term side effects that she needs to be concerned about?
That's a good question. And I suspect what she means is long-term side effects of using the inhaler, specifically the steroid-based inhalers. And yes, there are some potential long-term effect of using steroids in general. And what we tend to do is, with every treatment you give, is weigh the risk of giving that treatment versus the benefits of having that treatment. We know in asthma that if we don't get your airways inflammation under control and treat that inflammation appropriately with the right dose of inhaled steroids, you will end up with lots of exacerbation, potentially a severe hospital admission, and even death. Now, counter that with the side effects of steroids, and the common ones, although it's less so with the inhaled version of steroids, is things like your bone may thin, so you may get what they call osteoporosis or osteopenia, where your bones just lose the minerals in them. Your skin may get a bit thinner and at higher risk of bruising. The local effect of the steroids around the throat is some people may have a bit of oral thrush or infection in the throat quite often when they use the inhalers. But those usually, it's a very minor group of people who are on very high doses of inhaled steroids. The doses we give for asthma are very small to start with, or we may start a bit high and then lower it to a lower minimum dose that you need to maintain your treatment. So quite often we don't get this systemic effect of steroids with these doses of inhalers. The local effect may be related to the type of inhaler you have. So sometimes we may adjust your inhaler type if you're having lots of oral thrush. So to answer that question, bottom line is yes, there are some potential side effects of using the inhalers long term, but when you compare that small risk to the benefit that you get from getting your asthma properly controlled, it's a no-brainer for you to have the treatment that you need.
Oh, sorry, you hadn't finished. I thought you finished.
No, that's fine. I was going to say, in fact, we do get to a point with some people with their asthma that we put them on very high doses of tablet steroids, and even go as far as putting some more advanced treatment for asthma, like what they call biologics, to try and get their asthma under control, and forgetting about all the other side effects or potential side effects of the steroids.
Thank you so much. That's reassuring, and I think I like how you've connected that to the need for review so that the lowest needed treatment can be given, which again reduces the chances of potential side effects. I think, Donna, you can go away and look at as well things like technique on how to take the inhalers, making sure you wash your mouth, for example, afterwards. Is that correct, Dr. Njafuh?
Absolutely.
That helps to reduce the risk of having thrush, for example. Okay, we want to cover as many questions as possible. And personally, one of my favorite slides was around how you gave the expose of the inequalities between sort of white populations and Black populations, rates of hospitalizations, rates of death, and things like that. I've got Juliana here on Jinaka. I hope I've said that correctly, who's put in a question which I think might also maybe highlight why these differences are there. But she says, when you say the lips turn blue, is that for Caucasians? Is that the same as for darker skinned individuals as well? Do we turn blue? I've never seen blue lips on a Black person.
That is a good point, and it is indeed for the lighter skin, because it's easier to spot. But there are other areas as well of your mucosa that you can look at if your oxygen levels are low, just inside the mouth or the eyes as well. It can, but yes, it's not the easiest thing to spot. To be honest with you, you're getting to the point where you're visibly blue on the Black skin. That's already a bad sign. At that point, you probably are not breathing. So it's unlikely as a sign, as an early warning sign for our population. But I do agree. I
Mm.
agree with the question. Yes.
Yes, that's right. I guess there's other signs as well for a severe asthma attack, isn't it? Like breathing fast
Fast.
and
Yeah.
using chest wall muscles to breathe or
Absolutely.
tummy muscles to breathe. So that's something to think about. Juliana, on her Part B question, also wondered, can asthma turn into pneumonia?
That's a good question. Now, asthma itself cannot turn into pneumonia. What will happen though is if you get an infection that triggers your asthma, for example, people who have pneumonia, which is usually a bacterial or viral infection of the lung
Mhm.
tissue, you can get an exacerbation of your asthma as a consequence of that infection. In that the windpipes, because of the pneumonia, have also become inflamed, and then you get wheezy and you're more breathless. So asthma cannot become pneumonia, but infections, pneumonias can flare up your asthma.
Yeah. Thank you. That's great. Good morning to Bolaji. Bolaji is saying, do children outgrow asthma? And I'll link that to another question to save our time. At what age can children be diagnosed for asthma? Because obviously, with my parent hat on, I go with my child who's wheezing and they tell me, oh, we can't diagnose asthma. And yet, doctor, you've told us that asthma is one of the most commonest conditions in childhood. So please, can you elaborate on that?
Yeah, that's actually a very good question. And what I'll do is I'll divide it into two. So the first part is, can children be, or what age can someone be diagnosed with asthma? There's no cutoff age as far as I'm aware. Um, um, it all depends on the classical symptoms and some of the biomarkers. Now, there are obviously some tests that you cannot do in the much younger children, like the spirometry, the peak flows, all of those. They may find it really difficult to do. So you base it on your clinical assessment, the pattern of symptoms, and some biomarkers in their bloods, especially maybe their eosinophil count, total IgE, those kind of things. Now, bear in mind, I'm not a pediatrician or a pediatric respiratory consultant. So what my colleagues do with the much younger age, I would not be able to comment on that specifically. But as far as I'm aware, at any age, they can diagnose asthma based on the classical symptom. Now, I know very young children quite often get what they call viral induced wheeze or RSV type wheeze, and they usually tend not to class those as asthma. But what it tells them though is that this person may have asthmatic tendency, and they tend to keep a very close eye on those people just in case symptoms persist, occurs outside of viral infection, in which case they can then diagnose asthma in that scenario. So what they try not to do is diagnose asthma in someone who's got an acute viral infection as a child. In an adult, if you get a virus infection and you're wheezy, it's almost certain that you've got asthma tendency. Okay. We tend to investigate those in adults. Now, the second part of the question was, can people outgrow asthma? Yes. Quite often, people would have quite marked symptoms of asthma in childhood, early adulthood, or kind of adolescence. And then by the time they hit adulthood, for some reasons, symptoms just completely go away, to the point where they may even actually wean off their inhalers. And then they may never have it again, or later in life, it may reappear. So it unfortunately or fortunately, it can get better as you get older. But I wouldn't say determine that by yourself. Let the physician or the doctor looking after you decide whether actually your symptoms have got to a point where we need to get rid of your inhaler altogether.
Oh, that's fantastic. And just a note on that, just as much as children can outgrow, adults can also develop, isn't it? You can have late onset adult asthma. Do you want to say anything about that?
Yeah, so yes, so adults can develop asthma de novo, and again, it goes back to the chart I displayed earlier about the genetic susceptibility and the environmental aspects of it is as when you get so much exposure over time, unfortunately, it may get to a point in your adult life that you just meet a threshold where your immune system then becomes dysregulated and you develop asthma. So it's not uncommon for people to develop asthma in their kind of fourth, fifth, or sixth decade of life. So yes, it's a known phenomenon.
Yes. I suppose a comment on that from a GP perspective, doctor, given the recent up-to-date asthma guidance, which was updated last September. As you can appreciate, we are not specialists, so we're so dependent on, this guidance and whatever changes come. But I think as a general guide, what they've been telling us is sort of to wait until a child is around 5 years of age to start sort of doing pheno testing in the community. That's what they recommend us to do as a first line. And if the pheno testing, which sometimes is actually available, certainly in the practice that I work, we do pheno testing. So parents may be asked to take their children to get tested. And if that is negative, they can go on to have spirometry as well. But I think this is like a special note, a recent change with regards to how we investigate children.
Yeah, and I think part of that is that's the age where they can reasonably do those tests. Because the pheno test requires a lot of coordination to get of blood to get the marker in a certain place for you to get the result right, and for also to be able to do a spirometry, you need to be able to follow instructions and do so hence why it's a bit more challenging when people are a lot younger and can't follow that instructions. You can't really rely much on those particular tests. Hence why, yes, it is possible to still diagnose people younger than that, but you will have to depend a lot more on the clinical symptoms and some blood biomarkers rather than the objective measures on the pheno and the spirometry.
That is great. I think that is it. I'm just quickly going through our comments as a final to make sure I haven't left out anybody. Wonderful, wonderful comments for you, Dr. Njafuh. People are saying thank you very much. It's well presented. It's been instructive. It's been a very instructive health session from Juliana. Iyabo says thank you for this insightful present, Dr. Njafuh. You were thorough, and through all you were explaining as a layman, so very easy for us all to understand. So again, without further ado, thank you everyone for joining us. Please share this recording with all your loved ones, with anyone that you know who's affected by asthma, and hopefully we will be able to see you next time. Big thank you to Khan, my admin team. Thank you for organizing this, for having me as the host, for inviting Dr. Raymond Njafuh, a specialist in respiratory medicine down south of England. We appreciate you so much, and we wish you a great weekend. Thank you.
Thank you all.
Okay, bye-bye.
All right. Thank you, Dr. Raymond and Dr. Von. Thank you for this. Thank you for your contribution. Thank you for the knowledge shared. That was very, very insightful. That it was very informative and educative to us and to everyone on the call. I'd like to share my screen now. Yes, can you see my screen, please?
Yes, we can.
Okay, thank you. Once again, Dr. Raymond, you made us know a whole lot of things that has to do with asthma and the lungs today, how we should use the inhalers, and a whole lot. And Dr. Von, thank you for being a great host. That was very, very interesting. Thank you. Thank you for contributing to what CAN is all about. That is health literacy. We want members of our community to know what they should know about their health and well-being. Thank you. I'll just quickly like to take us through uh, upcoming events. Next Saturday is another time. That's 9th of May from 11. The topic will be shared during the course of the week. We want you to invite your friends, your loved ones, your colleagues to be part of this great session where they can learn more and more about their health. Um, okay, it's that time of the year again, the Africa Day. This will be coming up on the 28th of May here in Manchester, Suffolk to be precise. We'll be having a lot of business people from our community, people who have experienced over the years, and also we'll be having startup business owners too. So please come over. Let us do this together. Let us celebrate ourselves. Let us showcase what we can do. This year's topic is diaspora partnerships for trade, health, prosperity, and shared growth. There's a whole lot to learn. And please, for store bookings, reach out to us on Africa Day at can.org.uk or just scan the QR code and you have the opportunity of showcasing what your business is all about. Wow, drum rolls is the Black Healthcare Awards again. This is celebrating excellence in healthcare. This will be coming up on the 4th of July in London. We are coming together to put spotlight on our health professionals, with doctors, pharmacists, nurses, even students too that are in the health sector. Let's come and celebrate ourselves. The ticket is on. Kindly scan the QR code for your tickets. You can buy one for yourself or for your trust, friends and family members. We look up to seeing you on the day. It's going to be three-course dinner, live music performances. We have a whole lot to showcase on the day. These are our professionals. Let us celebrate them. That's what we are doing at this year's Black Healthcare Awards. Are you a counselor, or do you want to impact people's lives? This is an opportunity for you to be part of our counseling team. You're black or African or Caribbean, and you have something to share. Kindly send your CV to counseling@can.org.uk. We have opportunities where you can help people in the community to give them that shoulder, where they can give them the opportunity to express whatever they are going through. And this is a private session. Is kept as it is. I move on to the Red Ribbon campaign, Black Red Ribbon Champions. You don't have to leave, you know, facing HIV alone. This is an opportunity for you to have a one-on-one session with some of our professionals where they can guide you, tell you what to do, how to go about it. It's not a death sentence. It is not at all. You can navigate all this, and you don't have to be alone. There's no fear, or shame about it. Nothing to worry about. Just reach out to us, contact us at blkredribbon@can.org.uk, and someone will reach out to you on how to go about that. We have something called the Creative Health Service, where people come together no matter the age, where you can express yourself, express your creativity, be it in paintings, in arts, ceramics, textiles. Just come together. This is a safe environment for you. We have sessions in Bolton, Stockport, and Gorton. For Gorton is Mondays, from 3 p.m. to 5 p.m. At Stockport is Tuesday, every Tuesday, 1 p.m. to 3 p.m. And at Bolton is Wednesdays, 2 p.m. to 4 p.m. You can send us a mail at greenandartswellbeing@can.org.uk for more information. Oops. That's it for this week. We look forward to seeing you same time next week, Saturday. Thank you. Thank you very much, everyone, for logging in. Thank you. Have a great weekend. Thank you.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.